Hello, everybody. My name is Dr. Ann Loeffler. I'm the Deputy Health Officer for Multnomah County. I'm also a basic life support instructor, and we made this little brief video in order to give you confidence when you're helping in a COVID-19 vaccine effort. As you probably heard, there are some episodes of anaphylaxis associated with this vaccine, and even though they're uncommon, the CDC is currently saying 1 in every 90,000 vaccines. We know it's scary, and we wanted you to be a little bit more prepared. I prepared this PowerPoint with input from Dr. Joshi. He's the medical director of the Allergy and Immunology Clinic at OHSU. Thanks, Dr. Joshi. So in case you only have time to listen to this one slide, I wanted to remind you that anaphylaxis is a rare reaction, but it is a severe allergic reaction which can be life-threatening and needs to be treated immediately. The treatment for anaphylaxis is intramuscular epinephrine, and the place to inject it is the anterior lateral thigh. You can use an EpiPen, an AviQ, or a generic autoinjector, or you can use a syringe, which contains the 1 milligram per mil epinephrine, which we used to call 1 to 1,000. The dose is 0.3 milliliters. If you are ever giving epinephrine for anaphylaxis, you are calling 911 immediately, and you're helping that patient into a position where they can be stabilized. If they are safe to do so, the best position is on their back with their legs propped up. However, if that patient is vomiting or having upper airway obstruction and it is more comfortable for them to sit up, you should absolutely let them get into a position of comfort. And you need to monitor these patients very, very carefully because sometimes they need a second dose of epinephrine as soon as in 5 minutes, but could be up to 15 minutes later. All right, so that's a little background. They're going to be fine, you're going to be fine, and here's a little bit more information. Many people have mild allergic reactions to vaccines or other medicines, foods, etc. A more mild allergic reaction would be something like a bit of an itchy mouth, a few scattered hives, itchiness, maybe a little bit of mild nausea or discomfort. If people have a mild allergic reaction, not looking like anaphylaxis, which we'll talk more about in a minute, you can give them a dose of diphenhydramine, also known as Benadryl, 25 to 50 milligrams, or cetirizine, 10 to 20 milligrams. And if you do that, again, thinking this patient is having a mild reaction, not anaphylaxis, you're still going to watch them very closely because they may progress on to advancing to anaphylaxis, and in which case you're going to use that intramuscular epinephrine that we talked about a second ago. An antihistamine like Benadryl or cetirizine is appropriate for treating hives or itching, but does not address the airway compromise or the shock that can happen with anaphylaxis. So keep watching and move to treatment for anaphylaxis if needed. So a little bit more information about anaphylaxis. This is a severe reaction after an exposure. And in the case of what we're talking about today, this would be after a vaccine. So any number of body systems can be involved. Your lungs, and that might be evidenced by shortness of breath, wheezing, or some patients just have a repetitive cough. Your heart may be involved. The patient might look pale, they might look blue, they might faint, they often would have a weak pulse, feel dizzy, have a low blood pressure. Throat is another thing that we're going to be watching. They often would have swelling in their throat, and that might be evidenced by trouble breathing, swallowing, or a noise with breathing in called stridor. Their mouth might be involved where their tongue or lips are swollen. And of course, skin, many hives across the body, and sometimes with other skin findings or mucosal findings. And then finally, GI, and those patients might have vomiting, diarrhea, or abdominal pain. It's important to note that 80 to 90% of patients with anaphylaxis will have skin manifestations, but not all people, and those manifestations might be delayed. So this slide includes some pictures and also some of the words that describe the findings on the skin, like itching, hives, flushing, angioedema, airway tightening, mouth itching, and conjunctival swelling. The respiratory features are very, very dangerous and might look like trouble breathing, air hunger, cough, wheezing. Remember that high-pitched noise that comes during exhalation, which is caused by bronchospasm. the stridor, which comes when you breathe in because of upper airway swelling. If you had a pulse oximeter, you could see that the patient was hypoxemic, but sometimes they just look blue or dusky. They can have chest pain from that tightening of the airway. They can have a hypersecretion of their mucus and have a lot of coughing. They might just have hoarseness or trouble talking. These are all very, very dangerous signs that you should consider to be anaphylaxis in this circumstance. And the important thing to do at that point when you're considering anaphylaxis because of skin manifestations or any of these other features we talked about, you're going to start analyzing the patient's vital signs. Weak pulses and low blood pressure are signs of anaphylactic shock. Not all patients who have anaphylaxis are going to have anaphylactic shock, but this is just like breathing trouble, is one of the very dangerous features and should make you think of anaphylaxis and treat. Remember, the systolic blood pressure that we consider hypotensive for any person over 10 years of age is 90. If your systolic blood pressure is less than 90, you are hypotensive, and this is very dangerous. But if you think your patient has anaphylaxis because they have trouble breathing, because they have skin manifestations, you're going to do your BLS type activity that we're going to talk about in a second. You're not going to wait to get a blood pressure, but you're going to go in the direction of monitoring and treating with the epinephrine because that is going to be life-saving. Just a quick reminder that everything after a vaccine or in terms of a reaction is not necessarily anaphylaxis. So we're seeing a fair number of patients who receive vaccines who are actually just having a more simple fainting episode. We call that vasovagal. And some of the things that differentiate fainting from anaphylaxis are in this table. So those patients tend to have the reaction immediately after the vaccine. They get the shot, the administrator says, "You okay?" Yeah, they stand up, they get woozy. And if you check them at that point, they would be bradycardic, not tachycardic like you see in anaphylaxis. And they get pale and sweaty, cold and clammy, and just treating them by laying them flat, reassuring, and monitoring, those things are usually supportive treatment. Anaphylaxis, however, doesn't usually happen immediately after the vaccine. It usually happens after a few minutes of delay, and they almost always are going to have tachycardia. They're going to have maybe have the breathing issues, and they're going to have the skin manifestations, again, 80 to 90% of the time. So again, lots of times in this new vaccine era, we're seeing some fainting episodes, and it's very important to monitor people closely and to just think about the differentiation. These other things on the list would also be considered in the differentiation. A panic or anxiety attack, I think, is important to think about because there is a lot of press. There's a lot of public awareness of the risk of anaphylaxis. And so people who are anxious might have some anxiety. Those people would not tend to be hypotensive. They, of course, would not tend to have hives. So try to distinguish those things before you use the adrenaline or epinephrine. Just a reinforcement of some of the things that help you distinguish. And again, if it's safe to do so, assess your patient, reassure them as you move in the direction of considering whether anaphylaxis is what's going on in your patient. I mentioned basic life support, and we always start with ABCs. So A stands for airway. You're going to position that patient in a way that their airway is going to be best open. You're going to look for that stridor, that noisiness on inspiration. You're going to look and see if they're retracting, and that's pulling in at the skin, usually above the sternum in this case, and whether it takes them longer to inspirate. So they may need to get into a position of comfort, or if they're already down on the ground, you might help them position their airway to have the maximal air entry. You're going to assess their breathing to see how well they're getting their air in and if they have wheezing. And then you're going to check the strength of their pulses, their capillary refill, and whenever it's appropriate, you're going to check the diastolic blood pressure. Some people don't talk about D and E in the ABCs, but D is disability. Look at their neurologic status. Patients with anaphylaxis, not uncommonly, will be sort of unwell neurologically because their brain is not getting the perfusion that it needs. And E stands for exposure, where you're looking at the extent of the rash in order to understand if it's progressing. So again, life-saving intervention, not to be delayed, is IM epinephrine. And whenever you are in a situation where you're doing the epinephrine, you are calling 911. Before you start your shift, you're going to make sure you know what brand of epinephrine autoinjector or syringe you have available, and you're going to remind yourself of the features of how to use it. You're going to look at the expiration date. If it's an EpiPen brand, you can see the fluid inside, and if the fluid is cloudy or discolored, you shouldn't use it. If you're using a vial of epinephrine or a syringe of pre-prepared epinephrine, you're going to just double check that it's the concentration, 1 milligram per mil, and you're going to want to use 1 mil syringe, not a bigger syringe, a 1 mil syringe, 0.3 mils, and an appropriate needle to give an IM administration. So just if you happen to be using an EpiPen, and as a reminder in the title, don't forget you're calling 911 if you're in this situation. If you're using the EpiPen brand, you look at the instructions, but again, before your shift, just have some confidence. What I like to suggest is always think of holding that EpiPen like a dagger. Don't ever put your thumb over either end, because in a panic moment, you might have your thumb in a place where the needle comes out. You want the orange tip down. This is where the needle's going to come off. And come out of the autoinjector. You're going to take off the blue safety cap. You're going to place the EpiPen toward the outer thigh. You are going to go through the skin. You do not need to, through the clothes. You're not going to need to take people's clothes off. And you're going to do, with some force, swing that EpiPen or a different brand of autoinjector through the clothes into the muscle and hold force until you hear a click. This is going to be the signal that the needle is out and the injection is starting, and you're going to hold the device in place for a solid 3 seconds. This is a newer guidance. You don't need to do it longer, but 1,000, 2, 1,000, 3, 1,000. That's how long it takes to inject the medicine through the needle into the muscle. And then you're going to remove the EpiPen. You're going to massage the leg for 10 seconds, and then you're going to put the EpiPen back in the carrier for safety. We suggest that the patients take the device back to the hospital for disposal, as it's easily possible that you will not have a needle capacity there on your site if you're in a community setting. If you happen to look at the EpiPen, you'll see that there's still fluid inside because there's more than just that small dose, but you should be able to see that some of the fluid has been administered. And at that point, you're going to watch your patient closely while you wait for EMS to arrive. Most people don't feel great after they receive epinephrine because it stimulates the heart, so they may feel shaky. They actually may be more anxious. They might be a little paranoid. So you're going to calm and reassure them while you're watching all their symptoms and their vital signs. If they continue to have trouble breathing, if they're poor perfusion, as evidenced by weak pulses and maybe delayed capillary refill, persist or return, you can give a second dose of IM epinephrine as soon as 5 minutes later, but up to 15 minutes later. And the reason is twofold. One is there are some patients who are not that responsive to the epinephrine, and then some people's perfusion is so bad when they're in anaphylactic shock that they don't absorb the dose as well as you want them to. So if these patients are getting worse or never got better, be prepared to give a second dose of epinephrine. And hopefully right around then, your EMS team will be there. You're going to give them a concise handoff of what you did, including the interventions, including your times of observation. And if you have a structured handoff system like an SBAR, that would be ideal. So in brief conclusion, I know this was a very quick overview, but anaphylaxis is an uncommon but life-threatening reaction, which has happened after the COVID vaccines. And so whenever you're at a site that's vaccinating, you're going to be prepared to evaluate and treat for anaphylaxis while considering the possibility of the differential diagnosis. You're going to evaluate and stabilize your patient, making sure to also pay attention to the airway, breathing, circulation, but assessing them to see if they have the features that are suspicious for anaphylaxis. Again, 80 to 90% of people have skin issues, hives, mucosal features. You're always going to treat with epinephrine if they're having breathing troubles or shock. You're going to treat them if they have more than one feature that suggests anaphylaxis, like, for example, if they have the skin findings and they have GI findings, or they have the skin findings and they have dizziness or wooziness to suggest hypoperfusion to the brain. You're always going to call 911 if you're suspecting anaphylaxis and or having to use the adrenaline, and you're documenting the patient's symptoms and your treatment. be prepared to give that second dose in 5 to 15 minutes if the patient's not better or gets worse again. So I appreciate your time, and I hope this is helpful. Thanks again to Dr. Joshi from OHSU Allergy, and let's keep the good work going with vaccinating people and staying safe while we eliminate this risk to our community.